I'm a liver doctor down there, and the health board is named after Aneurin Bevan. So Aneurin Bevan grew up and spent most of his life not about 15, 20 miles from where I'm sat right now. And I think, as people will know, he was the founder of the NHS and a bit of a sort of political and personal hero of mine as well. And I think he was one of the most quotable politicians of all time, and an excellent orator. And I think one of my favorite Bevan quotes is this one, where he says, "The purpose of power is to give it away." So Bevan intrinsically understood that actually acquiring authority or the power to make a change about something wasn't of any value unless you could use it for good. And I think this was something that he very much epitomized in his political career. And it's something that many of us have tried to take forward over the intervening decades. So I think let's remember that phrase, because I think it's important, and we'll come back to it. The purpose of power is to give it away. So why is this relevant to this particular talk? Because I think it's relevant because the power gradient in healthcare has always traditionally lain with the system. And that includes doctors, nurses, and other allied health professionals that you, as individuals living with PBC or caring for people with PBC, will interact with and come across on a regular basis. And I think historically, patients have been reduced to a submissive or at very best, a passive role in their own care. So you were told what to do. This is what you needed to do. This is what we were going to do to you, not for you or with you. And I think that's been true for most of the modern medicine era. And this sometimes creates an adversarial dynamic. And if people are trained into a system where that's the norm, they will tend, on average, to behave in that way into the future. So it's beholden on all of us to start to challenge that dogma, challenge that particular way of behavior, and to bring about that change so that we can have a much better dialogue between the person suffering from the condition, their carers, and the people who have the power via the knowledge to make the difference in terms of access to the right treatments, to prevent complications, to treat symptoms, and provide a better quality of life. And I think it's fair to say, and I know Robert and I have had many conversations about this, I think that the progress that's been made in this area in the last 10 years in particular has been really quite phenomenal, but there's still such a long way to go. So I think it's really important we have these conversations and this dialogue to try and make the whole system work better for you as people who suffer from the condition and for those who care for people with it. So sometimes people talk about this concept of a zero-sum game. So a zero-sum game is where if one person wins, the other person loses. And I think what we need to consider healthcare partnerships as really a non-zero-sum game. There will always be an area of overlapping interests. There needs to become a win-win situation whereby the person gets access to the information that they require to treat their condition, to treat their symptoms, to have a better quality of life, to thrive with their condition rather than just survive with it. And from the clinician's point of view, that's hugely rewarding. Most people will get a reward from seeing people doing well. And all of us go into healthcare to try and make people's lives better. But sometimes system and other things get in the way. Now, showing my age in this respect as well, my other cultural reference, another great hero is Bruce Springsteen. So you can tell I'm not getting any younger by the fact that my cultural references here are either dead or in their 70s. But certainly, again, the boss is very rarely wrong in sort of matters of the human condition. And one of his favorite sayings is that nobody wins unless everybody wins. And I guess that's a little bit like Bevan's, the purpose of power is to give it away. It's that sense that actually, unless we can all thrive in society, unless we can all do well within a particular system, then ultimately nobody really wins. Just create an adversarial system, an adversarial approach where there are winners and losers. And there will always be an element of that, but can't we do better? And can't we try and smooth that gradient out so that everybody gets some sort of benefit and gets some sort of win? So let's think now a little bit about what partnerships actually are and how we can perhaps redefine them in this modern era rather than the sort of traditional paternalistic way the medicine practiced. So a generic definition of partnerships is that it's an arrangement where parties agree to cooperate to advance mutual interests, or from a medical perspective, that can be defined as the the interactive relationship between a doctor and a patient, the former advising on optimal strategies for improving or maintaining health, and the latter following the advice and taking charge of his or her own health. Now, even though the latter definition is from a relatively recent medical dictionary, it's still pretty paternalistic in its language. It's because it's more advising on rather than having a discussion about a joint way forward. So I think things are definitely changing in terms of there's a greater desire, not exclusively, but generally for clinicians to work much more in partnership with patients and getting that shared interest and getting that understanding of when we say we recommend this medication, not just take this, but explaining clearly why this is helpful, why it might have this side effect or that side effect, and how we might be able to manage those side effects or actually make sure that the medication is adhered to deliver the best outcomes for that person. So for me, this is about reimagining partnerships in the 21st century. And the UK General Medical Council, which is the regulatory body for doctors in the UK, produces this document, which is the duties of a doctor. And it includes work in or description or a recommendation to work in partnership with patients by listening, responding to concerns and preferences, give patients information in a way that they need it or that they can understand, respecting people's rights to reach decisions about their treatment and their care. These should only be recommendations about treatment and care, not mandates and not heavy-handed missives given down to people in a patronizing way. And ultimately, this is about supporting people in caring for themselves to improve and maintain their health, because nobody has a more vested interest in living a healthy life than you. So I think it's often worth considering what some of the challenges to partnership working are. And I've broken these down by healthcare professional and from the patient or carer perspective. And these are not exhaustive or exclusive, but they're just there to highlight some of the particular challenges I've seen. But it's always interesting to hear your perspective on this as well. But certainly from the healthcare professional one, the biggest frustration is a lack of time. There are usually too few of us and too many of you, so that we're often quite time poor when it comes to clinic assessments, and new patient appointments can be as little as 20 or 30 minutes at maximum, and follow-up visits can be 10 to 15 minutes. And that can be quite hard to deal with lots of complex symptomatology and having thorough explanations of your underlying condition, how it's affecting you and how we move forward. So time, I think, is undoubtedly a major factor in why communication is often quite poor between healthcare professionals or from the healthcare professional to patients. It's also important to reflect that sometimes healthcare professional knowledge and experience isn't as good as it could be in certain areas. And again, that's not necessarily an individual deficiency, but we know that within the UK, there's a shortage of highly trained hepatologists. Hepatology is a relatively new field, and although it's growing, there still aren't as many hepatologists across the UK as we would like. And so therefore, people are often looked after by generalists who have to look after many, many, many different conditions. And as medicine becomes more and more diverse and more complex, and there are more and more treatment options and assessment options for individual diseases, then conditions like PBC, which is relatively uncommon, then that can sometimes lead to a little bit of lack of knowledge around what the latest guidance and recommendations are for treatment. There's also, I've said, that traditional paternalistic mindset, and some people don't change their behaviors in that regard and have been brought up in that very paternalistic way. And that can be a real problem and a barrier to open, effective communication and partnership working. And some people, doctors, nurses, like all members of the population, have a spread of human behaviors, and some are just better at communicating than others. So some people aren't just naturally good communicators, but that's something that really all healthcare professionals should be working on. And I think I have seen a sea change in that over my 20-odd years as a doctor. From the patient or carer perspective, I think sometimes a challenge or barriers to partnership working can be having had a previous bad experience. Understandably, people can come into appointments with their shutters up because they've naturally feeling quite defensive about being treated poorly in the past, or being poorly communicated with, or had a long delay to a diagnosis. And I think that's a perfectly valid reason to make it difficult to build an effective conversation. Some people might feel intimidated. There is still that power gradient sometimes. We sit across, from people, with desks intervening us. It's kind of quite an adversarial, almost like an interview type approach. So, physical environment is quite important to this. Having clinics, most clinic rooms now are a little bit more softly laid out, where the desk is at right angles to the person, rather than, so you're sitting opposite that, because we need to try and avoid creating that or exacerbating that traditional power dynamic. And sometimes it's always struck me as some people will often trivialize their symptoms. When you ask people who are really suffering, they'll go, "No, I'm fine, I'm managing okay." And that's because some people either feel that we haven't got the time, or they're not going to be listened to, or sometimes people feel bad that the doctor hasn't fixed the problem. They might like their doctor, they might have a good working relationship with them, and they feel bad for bringing up problems, because previous treatments haven't worked. And I've certainly seen that many times over my career. So it's really important that you don't trivialize your own symptoms, and know how to be able to explain those in a very clear way to your healthcare professional. I think the other barrier sometimes is that there sometimes can be excess faith in medicine and science, and that there must be a solution to every single problem. And whilst we have lots of treatments now for PBC, whereas previously when you had one, we still are lacking in particular areas like fatigue and itch management for some individuals. And so, there's often sometimes a perception that there must be a solution to this problem because we can fix most things. Well, actually, particularly for relatively rare diseases like PBC, we often don't have as good treatments as we would like. And this is where clinical trials become ever more important. And I'm sure you've been talking about this over this conference. As I said, time barriers to successful partnership is clinical slots are relatively short, and sometimes we therefore run late, and that often adds to frustration from the point of view of the patient, and also and their carers, and also the medical staff. So I think it's something just to bear in mind that the clinics times are often quite tight, and we are not given the requisite time that we would like. I would much prefer to have as long as it takes to be able to deal with a particular problem. And so I think it's just something that for you to be aware of. It's not an excuse, it's an explanation of where the system is currently at. And as I've said, as your condition is relatively uncommon, you may have many questions that have been previously unanswered, particularly if you had a long journey to get to a diagnosis in the first place. Thinking about those knowledge barriers, as I say, just exploring these a little bit more detail. As I said, your doctor or nurse may not be that familiar with PBC as a relatively rare disease. And I've highlighted this lack of hepatologists in the UK. So in the last survey, which was about 8 or 9 years ago now, almost half of responding hospitals in the UK, or in England rather, didn't have a dedicated hepatologist. So they had a gastroenterologist who has an interest maybe in liver disease, or sometimes does absolutely everything within gastroenterology. And that's a very broad field, and it's almost impossible in the modern era to be completely on top of every single guideline with all those different conditions. And that's a real challenge, and we're working hard to fix that. And I think the situation has improved in the last decade, but we're still some way off having an adequately trained hepatologist in each hospital in the UK. And that's let alone having the requisite numbers. So, probably most hospitals of a decent size should have 2 or 3. So I think, and the other deficiency at the moment is some hospitals, and many in fact, don't have a specialist nurse to help provide additional resilience within their systems and services. And specialist nurses often do a really good job of providing holistic care. And so this is another area that really warrants development. And as I've said, there's still lots we don't know. We don't hold all the answers. So coming back to that importance of clinical trials. Paternalism, it's really it's that doctor knows best traditional way of practicing medicine, and this very much prevents that collaborative approach. And I think sometimes we are guilty, particularly time is short, in fixing on medical endpoints of treatment, particularly when we know that the things that might be affecting you the most, we often don't have good treatments for, and we don't like saying. Well, generally, human beings don't like saying "I don't know" or "I can't." And in medicine, we'd often like to think that we're fixers, we're problem solvers, and if we can't solve a problem, sometimes there's a natural tendency then to shy away from the problem and just not acknowledge it and address it because you don't have simple fixes. That's wrong, of course, but it's perhaps understandable from a human psychology point of view, particularly when you look at some of the time constraints as well. And I think the finding for me, and this is a phrase, this is the bingo, Robert, you probably didn't think I'd get 15 minutes into this without saying the words personalized medicine. But I think personalized medicine means many things to many different people. But to me, personalized medicine is about taking that personalized approach, understanding the person, their wants and needs, and tailoring your approach and your treatment to that person, because everybody is different in their wishes, in their needs. Their symptomatology can be very, very different. The severity of liver disease with PBC can be wildly different. The response to treatment can often be wildly different person to person. And so we have to tailor our approaches towards that. And this is where personalized medicine, or what personalized medicine means to me. Communication barriers, as I've said, time constraints is an ongoing issue. And hopefully some of this discussion now and ongoing discussions are to try and find some better ways forward, really, in terms of how we can make communication clearer from both aspects. So sometimes, clear communication on the above and the lack of time can help focus everyone on matters the most. For example, if you are quite short of time and the clinic's overbooked or whatever reason, sometimes just saying, this is how much time we have today, so it can focus everybody's mind so that the most pressing issues can be addressed first. It's always nice to engage in a discussion around how life is and holidays people have gone on and fun things people have done, because we like to get to know people as human beings as well as people living with a condition, but obviously time limits that. So sometimes having a strong focus on exactly how long we have to address things can focus minds. And the other important thing then is signposting to trusted information resources can fill in other gaps. So that we can say, well, we might not have time to explore all this today, but why don't you have a look at this site? So obviously the PBC Foundation carries a wealth of information, and there are other resources out there as well that might be able to give you more information on specific things. And then you can build on that at subsequent visits. So sometimes signposting and particularly to other communities can be a helpful way of filling in some of those gaps that the time constraints put in place. Ultimately, again, I think conflict helps no one, least of all you as people living with a condition and their carers. And I think, although this can be really hard, if you've had a really negative experience within a system before, if it's not been with that clinician, as hard as it can be, sometimes going in with a clean slate and saying, yeah, I will raise those frustrations, I'll make you aware of them, but now let's try and start afresh and let's find a way through. Because sometimes you can spend a long time in a consultation. You can spend most of the consultation dealing with somebody's anger from a previous situation. And I'm not blaming somebody. It's perfectly understandable sometimes the way people have been treated, that they are extraordinarily frustrated, but you're still not going to get what you need out of your consultation in that short, limited time. So it's not to sort of poo-poo or wash over those concerns, but get them out in the open, in an open and honest way. But, there needs to be open minds on both sides to try and move forward if there is or has been a conflict. I just post this from the previous PBC Foundation app survey. It's a little bit old now, but I think this is using patient-reported experience measures to identify gaps in communication between patients and clinicians. And this is a really important role the Foundation has undertaken over the last few years. And this is about, did the clinician tell you about your liver test results? Did they explain what they mean? And what we see within this is that 2/3, something 3/4 are having explained what the liver tests are, but lesser proportion are having that explained what that actually means in practice. And that is a barrier, I think, to you having a better understanding of your condition, and then have a better understanding of why you need to take the medications and persevere with it in certain circumstances. So I think this just nicely, these sort of snapshot audits nicely highlight some of the gaps we still have in our communication as healthcare professionals to you, and where we need to make some gains and some improvements. So how do we bridge that gap? Well, I think PREMs, I've already mentioned, patient-reported experience measures. There are also patient-reported outcome measures, which might be the proportion of people treated with ursodeoxycholic acid who meet the criteria for response, or the proportion of people who require a second-line therapy are actually receiving that second-line therapy. And the collaborative audit that the PBC Foundation was involved in within the UK is a good example of starting to gather some of that information. But it's about understanding a bit more than just clinical stuff about, does your blood test get better? Because your blood test might have improved, but actually you might not have serious liver disease and you might have horrendous symptoms. Camera's turned off. So I don't know what happened there. My camera turned itself off for a second. So sometimes people will have horrendous symptoms. They haven't got advanced liver disease, and the clinician might be totally focused on the degree of fibrosis, going, oh, what you're worried about, you haven't got any liver damage, you're not going to die from liver disease. But actually, if you've got horrendous itch and fatigue, that's of no benefit to you whatsoever. So it's about understanding, the greater understanding we get from you about what matters most to you, the more we can start to tailor our approaches and deliver better care through guidance, through education of other healthcare professionals. And one of the things that really struck me from the previous foundation patient survey was when they did that word cloud, which is a really good way of collating lots of complicated information and pushing forward the things that matter most. One of the things that came out most, you would have thought itching and fatigue, but actually pain really came out really, really strongly in that. And I think we don't necessarily ask enough about pain from associated joint problems and how that might impact on people. So I think this is an example, this is an area where the PBC Foundation has done more than anyone to lead on this work in PBC, but also within the liver field more broadly. So I think they're to be commended with that. So I'll blow a bit of wind your way there, Robert, and the team for all the great work you've done on that. So now a couple of sort of top tips, I suppose, from my perspective, and I'll be interested to hear your perspective about how you can better care navigate. So care navigation is something I think we do really poorly in the NHS for lots of different reasons, some of it time related, some of it knowledge related or attitude related. But actually this is a two-way process. And I think if you can be prepared, knowing that there are sometimes some real significant time constraints, is that if you're prepared and you know about your past medical history, it's surprising the number of people who come to clinic and don't know what, or can't remember what medication they're on, or they haven't brought it with them, or there's an assumption that the GP record will be automatically available to us. It's usually not. So current medication doses, what are your symptoms, timing of onset? It doesn't need to be written down in a big document, but if you've got that information to hand, then we can then get to the specifics of diagnosis, treatment, and supportive care much, much quicker within a limited time frame. So what exacerbates your symptoms? What relieves them? What's troubling you the most of your current symptoms? What do you want most at the consultation? Who is your caregiver in your local hospital? So understanding that can be really, really helpful. So if you're seeing a specialist nurse, but you've previously seen a consultant, knowing who that is, so they can go, oh, if I need to get hold of somebody, that's the person I need to get hold of. And crucially, I think the other thing is at the end is who to contact if there's problems, because increasingly, it's not available everywhere, but increasingly healthcare systems are providing access to email advice services or telephone services. Or if you've got a real serious concern, you can always contact the consultant or specialist nurse's secretary, and they can pass information across. So if you're really struggling, it's important to ask. And sometimes you might be redirected back to your GP because the issue might not be related to your liver condition. But it's always worth asking that question and being explicit about what you're requesting from them. So in terms of key PBC specific questions to ask, I think that the key ones are, what are my blood tests, specifically the ALP, but there might be other blood tests that are important if you've got a more advanced liver disease, such as your bilirubin and your clotting factors, for example. Do I need treatment? And if you're on URSO, have you responded to URSO? If you haven't, do you need a obeticholic acid or bezafibrate? Are there any other therapies available? Are there any clinical trials going for either my non-response in regards to your ALP level, or from your symptom point of view, particularly around itching, less so fatigue, because there aren't good trials running for that really at the moment. But the other important question is, do you have serious liver scarring? Because we don't do a biopsy these days to diagnose PBC, and I think that's generally a very good thing, but we do need to make sure that we understand how much damage you have to your underlying liver. So you don't need a biopsy for that. We can do non-invasive tests like FibroScan or blood tests called ELF that can often give us a guide to how much damage there is to the background liver. And that can be really, really important in how care is provided, and the importance of adherence to therapy is communicated to people. Because if you have advanced liver disease, it's really important you understand how important taking your medication is. So in terms of further PBC related questions, if you have cirrhosis, which will occur in about 40% of people with PBC over their lifetimes, what do I need to look out for? What are the symptoms? What are the sort of safety netting symptoms you need to report if you get them? So that could be fluid buildup, it can be brain fog, where things are, you get more forgetful or excessively sleepy or unreasonably so. And then crucially, who do you contact if those problems arise? What do you do if your itch gets worse? How can I manage my fatigue? And some of that will be signposting to information that the PBC Foundation hosts so well, or other resources. But it's important that you know where to go to for trusted information. So ultimately, as I've said, knowledge is power. So, and the purpose of power is to give it away. So if we own that knowledge, or if we hold it currently, it's beholden on all of us to pass that on to you. So understanding what is important in PBC, both in terms of what to look out for, in terms of your bloods, your symptoms, how we can manage that, what to report, how to report it, via which number, email service, whatever that happens to be. The more knowledge we share, the better we can understand PBC, because we get information back from you, and opening up that dialogue provides a better two-way communication process for us to understand more where we need to target our efforts, and we need to understand its effect on you. So whilst we do have the in-depth medical knowledge, you have the in-depth knowledge of the symptoms of disease and how it affects your life. And some of you very much so from the Q&As that I've been part of, and in individual clinical practice, are also medical experts in your condition, because you've done a lot of reading around it. So it's about bringing all that experience together and using that to deliver the best outcomes for you, and reducing your symptoms and preventing progression of your liver disease. So ultimately, sharing your experience is powerful and educational to us. So the purpose of power is to give it away. We need to give that back to you, so you can ask the right questions at the right time to get the care that you need and deserve. So this is moving. I think we need to move beyond just the bipartite partnerships between healthcare professional on the left. You can see I've even got a masked doctor on the left. So I think I must have done this talk during COVID. There's you on the right. The little interjoining symbol is a Celtic one, so I have to put that out there as a TAF, and I'm speaking to people up in Scotland and people from further afield as well. But certainly it shouldn't just be interconnecting between us. There are other brokers that play in this partnership as well, and the PBC Foundation clearly plays a big role in your lives, because so many of you are involved in this conference this weekend, giving up your time to do so. So it's really important that we all work collaboratively to develop this partnership better and make it better for you to deliver improved outcomes in relation to your liver disease and your symptoms. So in summary, I think developing partnerships are essential for high quality care in primary biliary cholangitis, and it's a really important time because there's more and more therapies going to become available for this. So that means there's more that we can do, but it's really important that we have that better shared understanding of how we can help get those medications to you, and that you can deliver the greatest benefit from them. Symptom burden, emotional well-being, and medication compliance, as well as long-term liver disease outcomes, can be affected by the success of a partnership. If we're not communicating effectively to you, and you don't understand why you need to take a medication, and then you stop taking it, that might have disadvantageous effects on you, and we don't want that. So developing mutual trust and respect, I think, is very clear, isn't it? That's integral to this process, but should be extremely rewarding for all parties. It's a non-zero-sum game. We can all win out of this, and feel satisfaction from the process whilst we treat your conditions. And as I've said before, the PBC Foundation has a crucial role in fostering partnerships and building that collaborative approach. So I started this little story by a quote from an Aaron Bevan, and I think it's also nice to finish on one. So another of his most famous quotes is, "This is my truth, tell me yours." And I think what I love about this Bevan quote, it just showed that this is a man who was willing to listen. He didn't just tell others what to do. He said, "This is what I believe. This is my vision. What's yours?" So I think this is now an appropriate time to sort of finish this talk. I'm 30 seconds before my 30 minutes are up, which is good. So this is an important opportunity now to hear from you about how we move this partnership approach forward. Over to you, Robert.
Okay, Andy, we've got some questions. We know how that's happening. Can you hear us? Well, there we go. Right, we're still getting that echo. Is it coming through, Andy, do you think?
I can hear you, yeah.
Oh, 1 minute.
Can you hear me?
We can hear you.
The microphone's turned off for you now.
Yeah, no, it's on the sound desk. Can
you
hear
I can
now?
hear you now.
Okay. So we're having an echo here, but we'll do our best. Right. Your signal went, so I just want to double check. Primary biliary.
Cholangitis.
Perfect. Right. Question for you. What resources are there, or would you recommend for the right questions to ask your clinician? Is there a definitive list?
Great question. I think the answer is probably no, isn't it? And I think this is something in terms of off the back of the 2-day meeting or 3-day meeting we had earlier in the year, Robert, wasn't it? Where we started to just try to develop a program of work of what needs to be done. And I think this is one of those areas where I think we need to work on, because there isn't a definitive list that I'm aware of at this point in time. So I think it's, there's informal stuff around, when you do Q&As, I'm sure there's lots of information in those that relate to that, but actually there's not a definitive list. So I think we need to develop that.
Okay, Andy, we try again.
Can you hear me?
Yep. Sorry, mate, we lost you halfway through that answer.
It's okay. I don't think there's a definitive list. I think, that program of work we've described now, Robert, isn't it, through the conference earlier in the year? I think this is the sort of work we need to develop off the back of that and off meetings like this. So understanding from you guys who are living with PBC or caring for people with it, what are the key issues for you, and then how do we empower you to ask those questions? So we need to develop that tool, I think, and that should come out of the work that we've started.
Okay, so I'm going to go completely off script and find out if Mo is listening into the conversation. And she's not. Maureen? The question has come up in terms of if there is a definitive list of questions that we can ask our clinician. Do you have any thoughts or views on that? So, okay, we have the EASL guidelines, which is very true, but
yes.
So Mo's about to come on now. So if you've not seen the new website, go have a look at the new website. The new app is coming out, and I believe there's a section in there that Mo might want to talk about.
Yes. Yeah, we are working on a new app, which we're hoping to release an updated version of the app later this year. And one of the areas we are working on is so that you have it on your phone and you have it with you, is a list of questions that you can take a note of. Also taking a note of your symptoms as well, so it's easy to chat through with your clinician. The symptoms you've had over the last month, 2 months, however much the time frame might be, so that they're all handy there and available for you. And also a place for you to note things that come up, so that when you go in to meet with your clinician, that you're prepared and you've got that information to hand.
Perfect, thank you. So again, between us, we'll get the answer. So thank you, Andy. Question for Dr. Yeoman. Do you find that patients' age, gender, ethnicity, or culture affect, now it says your ability, not yours personally, but affect the ability to develop a good clinician-patient partnership? That's a slightly
really good
question.
I think the answer will almost certainly be yes. because I think particularly if there are language barriers, you know, I think because although we use interpreters, we have no idea, as it's not our language, if some of that nuance is coming through the interpreter, if that makes sense. So I think that's it's a huge challenge that. In terms of, so that's in relation to linguistic things, which are not always ethnically related, but often are. So I think language barrier is definitely a big one. I think we have to factor in religious beliefs into that as well, so that we're sensitive to those things. You know, and you know, particularly think about you know, people if they're fasting during Ramadan, for example, how we might sort of modify our advice, but there's often good resources that are produced to help support people with that. Gender-wise, it's a really interesting one. I think it's not really well explored in the medical literature, and I think we need to do a lot more around what is the, you know, there's experience from other areas. So, for example, women are far less likely to receive optimal treatment for a heart attack because the symptoms are probably slightly different, and all the textbooks are written around the male experience. And so I think we still need to understand a lot more about the different. Obviously, most people with PBC are women, but there are men with it as well. But actually, are there sort of inbuilt or baked in behaviours within society that disadvantage women? I suspect they almost certainly are in healthcare. But we don't really understand where they are at the moment. So I'm sure there are variations in the ability to provide good care for people with those within those groups described. But at the moment, I don't think we truly understand where the deficiencies lie. But opening this conversation up is a good way of starting to understand that.
Perfect. Thank you. I appreciate that. One last question, if I may. So going back to the PBC audit, is there any information in terms of the demographics within the audit, and if people within certain demographics have better or less good care within?
Yeah.
So is there a way to explore that data and just look at it in a bit more detail?
So my understanding of that data is that there's not good ethnicity or demographic. You know, we know males and females, but obviously within PBC that gets very hard to tease out major differences from a retrospective audit, because that's what it is. It's not looking forward and asking people questions. I think all that sort of data can do is identify broad deficiencies, and then you target down, try and improve those deficiencies. But it almost needs prospective work that looks into the future to try and deliver that. I think there's a couple of things I'm particularly interested in. So health inequalities is a big bugbear of mine, and that can be around gender, it can be around ethnicity, it can be around deprivation as well. What sort of background have you come from? We know people from lower income backgrounds are less likely to receive optimal care. They're less likely to see their GP, less likely to see a specialist, and more likely to have poor outcomes in lots of conditions. So I think there's a lot more we need to do to minimize health disparities based on people's individual characteristics. So that's back to personalized medicine again, isn't it? Understanding that there are some poor outcomes in certain groups, but we don't yet have the information on exactly, and the audit doesn't give us that data, I'm afraid.
Yeah. Okay. Perfect. Thank you. Looking around the room, no more hands, no more questions. So enjoy the World Cup. Dr. Andrew Yeoman, thank you so much for joining us today. I appreciate your time.
Okay.
Thank you.
Good to see you all.